that more people will have to work with daily than with brain perfusion talk. So we all know what delirium is. We all know that it affects many of our patients. We all know that it's associated with many worse outcomes, with increased mortality, with increased cost, with PTSD, with going later to work, so that our patients suffer. So anything we can probably do to save our patients from delirium would be good. And delirium is a very complex thing. So it's not entirely clear why our patients become delirious, and there's many factors playing a role. This is a graph that Martin Smith and I drew for a short review we did in intensive care medicine. There's actually a lot of things we can't help, a lot of things that contribute to delirium, like the condition of the certain condition of the patient that we can't help, the condition with which he came in the ICU. Well, some of these that's our job to try to prevent this. This is probably something we can prevent. This is what I'll talk about. And there's many hypotheses on how delirium actually starts, but we do know that it has long-term consequences. And so I'm going to answer 3 questions in my talk. The first is, can sedatives contribute to delirium? Can we use them to prevent delirium? And which sedatives can we use to treat established delirium? So can sedatives contribute to delirium? Well, one of the hypotheses on the pathophysiology of delirium is that there's an imbalance in neurotransmitters, and that there's actually a reduction in cholinergic transmission and an increase in dopaminergic transmission. And this leads to the clinical image of delirium. This is actually one of my patients. And also what you can see on EEG, because there's also an EEG sign of delirium with slowing of delta, with increased delta activity, slowing alpha activity, and you can often see that in these patients. Now, there's more than these 2 neurotransmitters. There's also norepinephrine, there's glutamate. Impact on delirium is this study by the group of Arian Slaughter, and although there was a trend that the more anticholinergic drugs you gave, the more delirium, the more new onset or transit to delirium you would get, it was not statistically significant. But we do know that all these affect these systems, all these affect these systems. This is probably one of our most famous Belgians, Captain Haddock. So sedatives definitely mess with our neurotransmitters. Now, when it comes to sedatives, we've changed our practice over the past decades, right? And I'm sure the same happened here in India as in the rest of the world after the landmark trial by the CRESS group, the follow-up trial, the ABC trial, the Gita Mehta trial in Canada, and the Thomas Ström trial. We reduced sedatives. We tried to use them less because we know that giving too much sedatives is associated with worse outcomes such as length of stay, duration of mechanical ventilation, and even mortality. But what about delirium? What can these studies tell us about delirium? Well, in the first study it was not assessed. In the ABC trial it had no impact on duration. In the sleep trial there was no impact on incidence, and in the Ström trial I will talk to you about. Actually, the only of these 4 studies that showed an effect was the study where you tried not to sedate them. So in the first 3 studies were about waking up patients. This was a study where you compare not sedating against propofol and daily wake-ups. And so you could see that the percentage of patients with delirium was decreased. You can also see that about 1/5 of these patients didn't tolerate the no sedation regime, which means that 82% of them did tolerate it. Now, to me, and this might be a provocative slide to many, but to me, and I always tell this to my residents as well, there's actually not many absolute indications for sedation anymore. Actually, you should try not to sedate all your patients. And the only absolute indications to me that remain are where you give a sedative as a therapeutic. for intracranial hypertension, for example, where I was talking about, or status epilepticus. Severe respiratory failure is not an absolute indication, but only, of course, if you can't do lung protective ventilation without, or, of course, if you have to give muscle relaxants, you will sedate. Hemodynamic instability, to me, is not an absolute indication for sedation, apart when you have increased pulmonary vascular resistance, or when you have an ECMO that is in the femoral arteries and the patient will obstruct that. So then, of course, you will give it. And for palliative care or end of life. And all the rest, there might be indications, and probably, well, at least 18% in the Scandinavian study, but maybe more in some indication, might need it, but that's in other indications, to me, not an absolute indication to give sedation. Now, which sedatives can contribute to delirium? Benzodiazepines are highly suspicious of doing that. So the first study of that was by Pratik Pandaripandi from the West Eli group at Vanderbilt. And so apart from age, severity of illness, actually giving lorazepam was the most predictive independent risk factor for developing delirium. In a meta-analysis, though, of all the randomized trials on benzodiazepine versus non-benzodiazepine, this effect didn't come out. So there was no longer significant. And maybe the answer is that it's a pharmacokinetic rather than a pharmacodynamic thing, because this very interesting study by Arjen Sloter, prospective cohort study, actually showed that it's the continuous infusion of midazolam rather than a bolus that predicts a transition to delirium. So probably the fact that you give a benzodiazepine infusion which keeps them comatose for a long time is maybe more predictive than just the pharmacological effect of giving a bolus every once in a while. So sedatives can contribute to delirium, but maybe some sedatives can be used to prevent ICU delirium. So this is what the guidelines currently said. There's no evidence for pharmacological delirium prevention, not for haloperidol, not for dexmedetomidine. This was 2013. Actually, the only intervention that really will prevent ICU delirium probably is getting a patient out of bed, mobilizing them. For that, you can't sedate them, so that's another argument against sedation. These are actual pictures from my unit. This little kid has a ventricular assist device, so the box here behind is the thing that steers this ventricular assist device. He's riding a bike in the corridor. This guy is being ventilated while walking. And so this is actually, you can recognize it, the same corridor. So this is actually happening in my unit. And the Schweikert study showed that you have faster recovery and less delirium if you get the patients out of bed as soon as you can. But is there any data on which sedatives you could give to prevent delirium? Well, this is a meta-analysis of all the studies in 2015. So which intervention would lead to a reduced delirium prevalence? Actually, no significant. Which drugs? And there was a lot, I will tell you in 30 seconds. Which intervention could lead to a reduced length of stay? Yes, certain sedatives could, but I don't think this is a very good meta-analysis, because most people look at a forest plot and they see these diamonds and then they say, okay, it works. You can't read it from there, but the statistical heterogeneity of these studies is unacceptably high. It's more than 80%. And that's the statistical heterogeneity. But I think you can't even put them together, because these are like, I mean, almost 15 different interventions. Dex, clonidine, haloperidol, different comparators. So I don't think that, although it's a couple of very good friends from me from Brazil, who we will try to beat tonight in the football, by the way, made the meta-analysis. But actually, I don't think that you could put these studies together. So I don't think that this proves any evidence that there are sedatives you can use to prevent delirium or to influence length of stay. There's two recent studies. One study on dexmedetomidine in elderly cardiac surgery patients where they gave prophylactic dexmedetomidine, so they were not delirious, prophylactic during the first night in ICU. And you can see that the first 3 days there was a significant reduction in delirium. There was less incidence of delirium in the DEX group. They were faster extubated. The ICU length of stay was statistically significant, but clinically not, and no effect on other outcomes. And then a second study that was just published in the Blue Journal, also nocturnal low-dose dexmedetomidine in delirium-free patients either on other sedatives or no sedative. And here as well, more patients free of delirium, more days spent without delirium, less days with coma, and no significant effect on ICU outcomes. So maybe there's something in there. I know the resources are not always there in all settings to use an expensive drug as dexmedetomidine, but these two studies certainly point to maybe a probable or a possible effect in high-risk patients. What about the cheaper alternative, haloperidol? Can we use haloperidol to prevent delirium? The REDUCE trial, the Dutch trial? Well, actually, so they compared very low dose versus low dose versus placebo. This 3 times 1 milligram arm was, after an interim analysis, omitted for futility. So the end comparison was 3 times 2 milligram versus placebo. And they did this in delirium-free patients where they expected a length of stay of more than 2 days. So higher risk patient. They also used the pre-deliric score to assess the risk of delirium. No impact on survival, no impact on delirium, no impact on QT, which is a bit surprising maybe, but at this low dose it shows that it's maybe not as harmful as we always think, and no impact on length of stay and mechanical defenses. So haloperidol to prevent delirium is, at least from this study, again, negative. Maybe other drugs? Orexin. Orexin is a neurochemical that is activating, that's for instance deficient in patient with narcolepsy. Suvorexant is a receptor antagonist. A small RCT, 2 times 36 patients, where they gave suvorexant versus placebo in ICU and non-ICU patients. You could see that the patients on suvorexant that there were no patients who went to delirium. The red dots are the ones with a risk of dementia. And maybe the effect is, especially in these patients, is there. But so this study is too small to conclude. Melatonin is a thing that a lot of people are giving now. Actually, there's no evidence that it improves sleep quality in the ICU. Now, sedatives can contribute to delirium. Sedatives to prevent delirium may be dexmedetomidine. Can we use sedatives to treat delirium? So because that's what we're interested in, right? This hyperactive patient, what do we do? Well, what do we do? What do we use? In Europe, Brazil, and Canada, what do we use? Most of us use haloperidol. Some use benzodiazepines. Some use dexmedetomidine. Some use quetiapine. Some use olanzapine. What's the evidence? What's the evidence for haloperidol? I can just read the conclusion for you. There's actually no evidence to use that supports the use of haloperidol for delirium. So it's our most used drug. We have no evidence to use it to treat delirium. Other antipsychotics, including haloperidol, because haloperidol was also in this Cochrane, do they alter the course of delirium? Again, no evidence that it does. The Dahlia study, dexmedetomidine, I'm not by any means paid by Orion, by the way, so I will try to come to a nuanced conclusion, but it's the studies that are around. So the Dahlia study, Australia and New Zealand, 74 adults in whom extubation was esteemed not possible because they were too agitated, and they were randomized to dexmedetomidine versus placebo. The dex patients had more ventilator-free hours, had a faster resolution of delirium, spent less time agitated. So maybe dex can be used in that setting. Quetiapine, a very small trial, often quoted. And I think it's a very interesting trial, but unfortunately we need confirmation in a larger trial. So they started with quetiapine 2 times 50 up to 2 times 200 titrated on top of as needed haloperidol in only 36 adult patients with delirium, but still quetiapine, less percentage of time in delirium, less recurrence of delirium, so once they were delirium free, did it come back, less percentage of time spent agitated. So that's an interesting drug that we actually use a lot in our unit, added to haloperidol. And I'm almost done. So my conclusions are, of the 3 questions, and I don't know whether I put 3 question marks, so I'm maybe confusing you more than helping you, but can sedatives contribute to ICU delirium? I think they can. They make you comatose, and being comatose for a longer time makes you delirious. They don't allow you to mobilize, and that's maybe the most important thing. They mess with your neurotransmitters, although we're not quite certain how that exactly works, but they do that, which, well, benzodiazepines are very likely to be bad, especially in continuous infusion. Opioids and propofol, I didn't show the data because, for sake of time, but the effect is uncertain. And the dexmedetomidine might be the best choice in those at risk, if you can afford it, of course. Can we use sedatives to prevent delirium? Actually, again, here, I think I've shown the huge gap between research and practice. Haloperidol, the one study that has been done was negative. Dexmedetomidine, I think it needs confirmation in other patient groups, but there might be an effect in certain subgroups of patients. I still think that trying not to sedate is the best prevention of ICU delirium, and that's what we really should do, and that is a lot cheaper than giving dexmedetomidine. And the only evidence-based measure to prevent delirium is to get them out of their bed and mobilize them. Now the last question, which sedatives should we use to treat delirium? Here again, insufficient evidence, gap between research and practice. You can follow the guideline and say, okay, I'm going to use haloperidol and then other stuff, but as I've shown you, there's no evidence actually to support that. Dexmedetomidine might shorten it. Small studies that need confirmation. Quetiapine is interesting. It's not as expensive as dexmedetomidine, and the study was small, but it was very well done. And then there's a couple of future trials coming up. Prodex, nighttime dexmedetomidine versus placebo for a therapeutic reason. The 4D trial, again, dex versus placebo therapeutic. Nighttime dexmedetomidine for prophylactic reasons in cardiac surgery. Haloperidol, ketamine, or both versus placebo, prophylactic for scheduled surgery. So maybe we will learn more from these trials that are being done now. And so with that, I hope I haven't confused you more, which would be bad in a talk about delirium. And I think we have the questions now then. Or
Thank you, Dr.
Okay, thank you.
The session is open for questions. May I just